Welcome to MediCrush, where I help you crush your medical examinations. In this video, we will be covering cephalosporin antibiotics made simple and easy. Now, the name cephalosporin derives from the fungus Cephalosporium, which was a plant pathogen that was found to have antimicrobial properties. Today, most of the available cephalosporins are semi-synthetic derivatives of the compound that was found in that fungus. To understand the chemical structure of cephalosporins, the core structure is a four-membered beta-lactam ring that is the active component of the antibiotic and is a property that it shares with its cousins, penicillins. What makes cephalosporins different than penicillins is the fused dihydrothiouracil ring that is fused to the beta-lactam ring. And the R or side chains, the R groups, are how we can develop many different versions of cephalosporins, whether it be first, second, third, and fourth generation cephalosporin. We have to first start with an understanding about bacteria. Bacteria have cell walls that are predominantly made of a peptidoglycan layer, and this peptidoglycan layer is found in both gram-positives and gram-negative. It's thicker in gram-positives, but it's also found in gram-negatives. What happens is this peptidoglycan layer are fused together or linked together via an enzyme called penicillin binding protein or peptidoglycan transpeptidase. So it cross-links the peptidoglycan layer and is responsible for making this bacterial cell wall nice and strong and maintaining this cell wall. So think of it like this. Think of peptidoglycan as the bricks to a wall, and then think of the penicillin binding protein, or PBP for short, as the mortar or the cement that holds the bricks together. So with that being said, the beta-lactam family, which is composed of things such as cephalosporins and penicillins, they pretty much attack by binding and inhibiting the active site of the penicillin binding protein. And by doing that, it disrupts the cell wall integrity. Think of it almost like the big bad wolf that will blow down the house. So what happens with the penicillin is that it inhibits that active site. And if you inhibit that active site, you get cell lysis and cell death. A very interesting component of cephalosporins are that they are naturally intrinsically active against beta-lactamase producing bacteria. Some bacteria got smart and said, okay, you have this beta-lactam ring. They made an enzyme that breaks down the ring to make pretty much these antibiotics ineffective. But because of that fused ring, the dihydrothiouracil ring in cephalosporins, they are intrinsically resistant to breakdown by these beta-lactamase bacteria. Now, there's always a war between us and the bacteria. We're always trying to make antibiotics to fight the bacteria. The bacteria always tries to evolve to evade our antibiotics. So the ways that you get resistance, besides being bad stewards of antibiotics and our patients not taking them fully, is that these bacteria can produce other beta-lactamase that can inactivate cephalosporins. Or they can make it very hard for the cephalosporin to penetrate the membrane. And the last way is that they can also make changes in the penicillin binding protein through evolution and mutation. One of the famous ones is Staph aureus. So for example, methicillin-resistant Staph aureus are naturally resistant to most cephalosporins, with two big exceptions, ceftaroline and ceftobiprole. In terms of pharmacokinetics of cephalosporins, they can be both excreted either via the liver or the kidney. Most cephalosporins are excreted via the kidney. That's the major elimination route. There's a very important exception, and that is ceftriaxone. The main elimination route of ceftriaxone is the bile, and that has two very important clinical indications. The first is that if someone has renal insufficiency, you do not have to renally dose cephalosporins because they're mainly excreted via the bile. The second one is that we prefer not to use ceftriaxone in neonates because it is excreted via the bile. Remember that neonates have issues with the UGT enzyme that conjugates bilirubin, and so they have trouble dealing with bile to begin with as a neonate, which is why many of them are born with jaundice. So in this case, if you gave a drug that is excreted mainly via the bile, it can make it harder for neonates to get rid of the medication. In terms of the spectrum of activity, we kind of loosely, and I'll use that word very importantly, loosely categorize them into 5 generations based upon their spectrum of activity. Simply put, you get increasing level of gram-negative activity as you go from first generation to fourth generation, but you sometimes lose some gram-positive activity from the first to the fourth generation. So let's talk about the first generation cephalosporins. The 2 most important spectrum of activity for these antibiotics are that they're really, really great for gram-positive cocci, especially Staphylococcus species and Streptococcal species. They're not as great for gram-negative rods. However, there are a few gram-negative rods that are very important. And most of these are what we call the urinary coliforms, like E. coli, Proteus, and Klebsiella. There is some anaerobic activity. However, it has limited anaerobic activity. So it's not the drug of choice cephalosporin-wise if you're worried about anaerobes. But again, there is some limited anaerobic coverage, and there's no enterococcal coverage. Cephalosporins are intrinsically not effective against Enterococcus species. The 3 most important indications that you will be tested on about the first generation cephalosporins, because they're good for gram-positives and good for staph and strep, they're really great for uncomplicated skin and soft tissue infections in which you worry about staph and strep. For example, cellulitis or infective lactational mastitis. In that same vein, if someone is going to go for surgery and you're going to cut through the skin, you want to protect against those bacteria. So it's great for surgical prophylaxis prior to doing some kind of surgery. The third one is because it is great against urinary coliforms, it is a great drug for urinary tract infections. My mnemonic for this is Lynn drove her Lexus to the surgery clinic on the 1st of the month to remove a soft cyst in her skin. Why do I say that? Because the 1st of the month equals first generation cephalosporins. Lin is for cefazolin. Drove is for cefadroxil. Lex is for cephalexin. Those are the 3 important first generation cephalosporins. They're great for soft tissue infections, great for cystitis, skin infections, and for surgical prophylaxis. Those are the most important testable things about your first generation cephalosporins. Now, the second generation cephalosporins, they get greater gram-negative coverage, and they have a slightly weaker gram-positive coverage. The additional gram-negative coverage that you see with these antibiotics are Neisseria meningitidis, Moraxella catarrhalis, and H. influenza, especially for cefuroxime, is really great against H. influenza. There's a subgroup of these second generations known as the cephamycin subgroup, and the 2 antibiotics that are very important in this subgroup are cefoxitin and cefotetin because they have increased anaerobic coverage. If you get a question and it's asking you for cephalosporin that has great anaerobic coverage, look for these 2 antibiotics, cefoxitin and cefotetin. Because it has pretty great gram-negative coverage and some gram-positive coverage, they're great for skin, respiratory, ENT, and urinary tract infections. Cefuroxime, in addition to having H. flu coverage, it also covers Pasteurella multicida, which is the most common organism associated with cat bites. Now, we prefer to use amoxicillin clavulanic acid for cat bites, but if someone has a mild penicillin allergy, cefuroxime is one of the alternatives that you can use to treat someone with a cat bite, and we often add some kind of anaerobic coverage with this, either metronidazole or clindamycin. The other very important use of cefuroxime is for Lyme disease in pregnant women. We prefer doxycycline generally speaking for Lyme disease, but in pregnancy, we prefer not to use doxycycline, and cefuroxime is an alternative to doxycycline. Again, that cephamycin subgroup has really great anaerobic coverage, so it is great for any kind of anaerobic infections, specifically abdominal and pelvic infections. A couple of pelvic infections, for example, will be tubo-ovarian abscess and pelvic inflammatory disease treated as an inpatient. We will give them IV doxycycline plus either cefoxitin or cefotetin for that anaerobic coverage. My mnemonic for this is a pregnant fox in a robe used Clorox bleach to whiten her teeth and 2 limes for her sore throat. The 2 is for the second generation cephalosporin. The fox are for cefoxitin and cefuroxime. Anaerobe is because it covers anaerobic infections. Again, remember, cefoxitin and cefotetin are great for anaerobic infections such as abdominal and pelvic infections. The Lyme in the pregnant fox has to do with the fact that if you have Lyme disease and you're pregnant, you can use amoxicillin or cefuroxime as an alternative. And the throat part is because they're great for ENT, skin, and respiratory infections. The Clorox comes in because cefaclor is an example of a second generation cephalosporin. And the Tetan, the teeth is because the Tetan for cefotetin and also for bites with the teeth for cats, you can use cefuroxime as an alternative to amoxicillin clavulanic acid. Now, third generation cephalosporins, they're what I call the workhorse of the cephalosporins. Especially for like inpatient diseases, we use these medications a lot. Now, because of the third generation, it has broader gram-negative coverage, including Serratia, H. flu, and also very importantly now is Neisseria species, both Neisseria meningitidis and Neisseria gonorrhoeae. Also very important is that ceftazidime has additional coverage for Pseudomonas, whereas the other cephalosporins do not. It has less gram-positive activity because, again, going from first to third generation, you lose some gram-positive, but it's still ceftriaxone, cefotaxime, and ceftazidime have excellent anti-streptococcal activity, so it's good for pneumonia, especially strep pneumo, and even for the gram-negative organisms. Another great thing about those 3 antibiotics, ceftriaxone, cefotaxime, and ceftazidime, is that they cross the blood-brain barrier, so they have good CNS penetration for things such as bacterial meningitis. And as I said to you earlier, because ceftriaxone is predominantly cleared through the bile, it is safe in patients with renal insufficiency, and you don't have to dose them based upon the renal insufficiency. Some very important indications for the third generation cephalosporins, the workhorse of the groups, is Neisseria species. Again, it's great for bacterial meningitis because it covers the 2 most common causes of bacterial meningitis, which are strep pneumo and Neisseria meningitidis. Ceftriaxone is the drug of choice for gonorrhea. They are great for community-acquired pneumonia. As a matter of fact, these are the cephalosporins that have the most activity against penicillin-resistant pneumococcal strains. For Lyme disease involving the heart or the brain, or in pregnant women, you can use these third-generation cephalosporins. They're also great for urinary tract infections, both acute cystitis, and they're great for pyelonephritis. If someone has acute otitis media, we prefer high-dose amoxicillin. But if they have a mild penicillin allergy, which you cannot use high-dose amoxicillin, you can use cefpodoxime, cefdinir, or oral cefuroxime, which is a second-generation cephalosporin. All 3 of these antibiotics have broader gram-negative coverage, and they include H. influenza, strep pneumo, and Moraxella catarrhalis, which are the 3 most common causes of sinusitis and acute otitis media. There are also alternatives for aminoglycosides in treating gram-negative infections because, remember, aminoglycosides are nephrotoxic and ceftriaxone is safe in renal insufficiency. Also very important about ceftriaxone, it is often combined with vancomycin because, again, it can give you a broad spectrum coverage for empiric treatment of many different conditions. Some big ones are meningitis for ages 1 month or older to 50 years of age. For bone and joint infections such as osteomyelitis, spinal epidural abscess, or septic arthritis, that's a great empiric management and is also great for infective endocarditis. My mnemonic for this is the nice new orthopedist Taz tries to fix the skull bone with an axe while eating key lime pie for dinner. Nice is for Neisseria species. These are great, ceftriaxone especially. New for pneumonia, right? Orthopod for cefpodoxime. Ceftazidime Taz tries to fix for cefixime, and axis for ceftriaxone and cefotaxime. The skull bone, again, because they're great for bone infections such as osteomyelitis. The lime is for Lyme disease, again, for the heart or the brain or in pregnancy. The pie is for pyelonephritis, and the dinner is for cefdinir, which is great for ENT, respiratory, and skin infections. The 4th generation that's very important to know is cefepime. Now, it is what I call the best of both worlds. It has a very broad spectrum of activity. What do I mean by that? Well, its gram-negative coverage is similar to the third generation cephalosporins with an added benefit. Now, cefepime also is the great drug for Pseudomonas aeruginosa. That's very important to remember about cefepime, is that it's great against Pseudomonas. In terms of its gram-positive coverage, it is very similar to the first generation cephalosporins. Remember that the first generation has excellent gram-positive coverage. So it has the best of both worlds, with the added benefit of now also covering Pseudomonas. Not commonly talked about, but we call the space organisms. Cefepime has increased activity against most of the space organisms, against Serratia, Proteus, Citrobacter, and Enterobacter. It is not great against Acinetobacter, but again, for most of them, it has good coverage for those bacteria. Another very important fact about this is that cefepime has the most resistance to beta-lactamase compared to the other cephalosporins. And it can also cross the blood-brain barrier, which can make it an alternative for bacterial meningitis. Because of its broad spectrum activity, we kind of reserve these for infections due to multi-resistant organisms. Some other situations would be like meningitis that's severe, pseudomonal infections that are severe, hospital-acquired infections, and even febrile neutropenia. My mnemonic for cefepime is C, that it copies the third generation cephalosporins in terms of when would you use these antibiotics. E for exclusive, we try to reserve these antibiotics for serious infections. The FE for cefepime is for febrile neutropenia and fever of unknown origin that is severe. The P in cefepime is for Pseudomonas aeruginosa. It's good against Pseudomonas, and also it is the most effective against penicillinase or beta-lactamase producing bacteria. The IM is for it is ineffective against MRSA, and the E in cefepime is for epilepsy. Of all the cephalosporins, cefepime is most strongly related with seizures. The fifth generation cephalosporin, ceftaroline, has a broad spectrum of activity, especially for gram-positives. The most important special unique feature about this antibiotic is that it covers MRSA. There's only two cephalosporins that cover MRSA, and they're both in the fifth generation class, which is ceftaroline and ceftobiprole. They have a gram-negative activity, but less activity compared to the third and the fourth. They're great for skin infections, especially where MRSA is concerned, in which you cannot use the other drugs for MRSA, and they're good for a severe community-acquired pneumonia. Limitations include it does not cover Pseudomonas or gram-negative anaerobes, and it does not cross the blood-brain barrier. The newer Cytophore cephalosporins are great because in addition to how they normally work, they also can penetrate bacteria through ion channels, so they have additional way they can attack the bacteria. We reserve these for, again, severe multi-drug resistant bacteria. Important adverse effects of cephalosporins is they can cause GI side effects, nausea, vomiting, diarrhea, abdominal pain. In terms of hypersensitivity reaction, there's a 5 to 15% cross-reactivity with penicillins. We believe it's much less, like around 2 to 3%, especially the first and second generation cephalosporins. Now, if someone has a mild penicillin allergy, you can use a third generation cephalosporin like cefdinir, cefpodoxime, or ceftriaxone. You can even use the second generation cefuroxime. Because again, from third on, they have less activity against cross-reacting against penicillins. Very low incidence of hypersensitivity reaction to just them without a penicillin allergy, about 1 or 2%. They can cause drug-induced autoimmune hemolytic anemia, specifically warm autoimmune hemolytic anemia if the cephalosporin binds to the red blood cell membrane. They can also cause a disulfiram reaction, especially cephalotetin. If someone drinks alcohol while on these antibiotics, they can get nausea, flushing, headache, and rapid heartbeat. And again, ceftriaxone can cause issues in neonates less than 1 month because, again, it is excreted via the bile. The cephamycin subgroup of the second generation cephalosporins can also cause vitamin K deficiency, which can increase the risk for bleeding. And again, cefepime has the highest risk for seizures. And again, they can also have a slightly increased risk for nephrotoxicity, but ceftriaxone is usually safe in patients with renal insufficiency. So now, let's do some practice questions. When you see the question, pause the video to give yourself enough time to answer the questions. So which antibiotic here has the same mechanism of action as cefazolin? Remember that penicillins also work with the beta-lactam ring. They bind against penicillin-binding protein and inactivate it, inhibiting cell wall synthesis, making the best answer here amoxicillin. In terms of methicillin-resistant Staph aureus, there's only 2 of cephalosporins, and ceftaroline is one of them, and therefore it is good against MRSA. For Pseudomonas infection, if you're going to pick a cephalosporin, you have 2 options, either ceftazidime or you could use cefepime. Remember that cefepime is a great drug for Pseudomonas. We reserve it for severe infections, but it does cover Pseudomonas. In this case, you have a 20-year-old female. She's breastfeeding. She has a warm, hot breast. That sounds like mastitis. So you worry about a skin and soft tissue infection. Remember that first generations are great for skin and soft tissue infections. So in this case here, cephalosporin, cephalexin would be the best treatment of choice for this patient. This patient is at 10 weeks gestation and she has Lyme disease. In that case here, remember pregnant Lyme, the fox, so therefore I'm going to use either cefuroxime or amoxicillin are safe during pregnancy for Lyme disease. In this case, she's going to undergo a C-section, which is going to be a surgical prophylaxis necessity. So therefore, for surgical prophylaxis, again, we use our first generation cephalosporins. They're great for skin and soft tissue infections and to prevent them making cefazolin the preferred answer here. In this case here, young female, fever, chills, abdominal pain, pelvic motion tenderness, vaginal discharge. You worry about pelvic inflammatory disease. Remember that for pelvic infections, especially treated as an inpatient, since she's vomiting and has a high fever, we're going to use a 2nd generation cephalosporin, such as cephalotetin or cefoxitin, plus doxycycline to cover for chlamydia. In this case here, this little kid has otitis media, but they have a penicillin allergy. So in this case here, we want to use cefdinir, which is a 3rd generation cephalosporin, is good for skin ENT infections, or cepodoxime or cefuroxime. The 1st generation cephalosporins and some of the 2nd generation have the highest association with cross-reactivity because they are very similar with the R side chains to penicillin G. The 3rd generation on and cefuroxime are safer for patients with penicillin allergies. In this case here, a 21-year-old female has what seems like a tubal ovarian abscess, which is a pelvic infection. Remember that your 2nd generation subgroup, which is the cephamycin, cefoxitin, and cefotetin, are great against anaerobes, and therefore that would be preferred treatment here. Again, with doxycycline, because we treat it very similar to pelvic inflammatory disease. Young male with a purulent discharge with gram-negative cocci pairs is hallmark for Neisseria gonorrhea, and with that ceftriaxone is a preferred drug for gonorrhea. Remember, the NICE in the 3rd generation stands for Neisseria species, and therefore would use ceftriaxone. Patient was bitten by their cat, and they have a history of penicillin rash. We prefer to use amoxicillin cladolinic acid for cat bites, but if they have a mild penicillin allergy, in this case here, you could use cefuroxime with clindamycin for its anaerobic coverage. So the cefuroxime will cover Pasteurella multicida, and the clindamycin will be added for the gram-positive and anaerobic coverage. I hope that made this easy for you. If it was, please like this video. Please comment, let me know which part of this video was helpful for you. And again, please share this video. Sharing is caring. Last, please subscribe to my channel. That way you can be notified when new videos drop. And once again, you crushed it.